Good evening, everyone. Thank you for joining us tonight. My name is Jane Beeman, and I'm the Director of Professional Relations for Euclid Systems. And I'm going to start out our webinar tonight. I want to start by thanking each of you for taking your valuable time away from your practice and your families to join us. Dr. Morrison and I have known each other for quite some time now, and I always find tips and tricks from her presentation to take back to the clinical practice. So I hope you do tonight. Now, we're going to start today by catching up. A few of you may not know Euclid. So let me give you a little bit of an overview about who Euclid Systems is, because especially in the US, you may not know us yet, but Euclid is a company that's over 24 years old now, and we have a focus that only includes improving the lives of patients with myopia. Euclid doesn't produce any products except orthokeratology. That's our focus, it's our study, it's our research, and it's our product design. We now provide more Ortho-K lenses to eye care practitioners than any other company. And tonight, we have nearly 2 million lenses on eyes around the world. Euclid was also a pioneer in receiving government approvals. Euclid products were approved by the US FDA in 2004, quickly followed in China with approval in 2007. Euclid had the first US Ortho-K lens to be approved in Japan and Taiwan. And of course, we are the first US-based company to have our own wholly owned Chinese subsidiary. Now, Euclid has a long history of working with very sophisticated Ortho-K designs. We use them to develop what is considered a very straightforward fitting protocol. With the Euclid system, there's no reason to purchase an inventory or even a trial set. We use our proven fitting algorithms to give you a high success rate in just a few short office visits. We also operate a state-of-the-art manufacturing process here at our Sterling, Virginia offices, where we ship lenses to all of our customers around the world, ensuring the highest of quality and reproducibility. Now, let me also start by saying this presentation tonight will express the opinions and the use of contact lens products as utilized by licensed eye care doctors. It may not reflect the FDA definition for orthokeratology or even the specific approved use of Euclid products, just the opinion of our speaker. Now, it's going to be helpful to us tonight if we know a little bit about those of you who are joining us. So on your screen, you'll see just a couple of quick questions. And if you would take a moment now and answer these questions, it'll give us a little bit of information for Dr. Morrison and myself as to who's in our audience and what you're currently doing with orthokeratology. Okay, everybody, final minutes, final responses, please. We've got a few people joining us now, so they're catching up on our polling. So we're going to give them another few seconds here. All right. We have a couple of Euclid people who will be popping in and out tonight with me. I've introduced myself. I'd also like to introduce Laura Glady, who works with us, and she'll be giving us some response results here. Laura, let's see, what have we got?
Thank you, Jane. Looks like we've got about 60% of you are currently fitting orthokeratology, and about 20% of you are not, with 20% of you responding NA.
Excellent. You know, this is designed to give you those basic stepping stones to getting started with overnight orthokeratology and to understand a little bit more about myopia management from Dr. Morrison. Okay. I'm trying to get rid of this poll. Hang on, there we are. Okay, so let me introduce our speaker tonight. Dr. Sheila Morrison received her doctorate and her master's in vision science. She did a residency in cornea and contact lens, all at Pacific University College of Optometry. In the past, she served also as faculty at the University of Houston College of Optometry. Today, she is in practice at Mission Eye Care Center for the Dry Eye and Corneal Disease in her home city of Calgary, Alberta, Canada. She is also a clinical rotation site instructor for the University of Waterloo College of Optometry in Ontario. Sheila has special interest in areas of comprehensive ocular surface topography, medically necessary specialty contact lenses, and of course, myopia management. She is a board member of the Cornea and Contact Lens section of the Canadian Association of Optometrists and also a fellow in the Scleral Lens Society. So I want you all to take a moment, and help me welcome Dr. Morrison and her presentation for this evening.
Thank you so much, Jane, for that nice welcome. I really appreciate and want to thank the folks at Euclid for having me to spend time with you tonight. The previous webinar done in this series by Dr. Dave Kading was hosted in the spring, and it gave an overview of, where are we at today in myopia management, giving a bit of a background in, where we're at in clinical practice and sort of the treatment options that are available for us. As we know, myopia has become a very, very hot topic in industry and research. I'm actually sitting here tonight with my current fourth-year intern, Alia Kapilani from the University of Waterloo. And you guys, the reality is that all new grads from 100% of our North American schools are coming out today with some level of training in myopia control, which I think says a lot. And it really puts the responsibility on all of us here to continue to keep up with the standard of care. And in this segment, we'll focus on orthokeratology as one of the tools. So I'll be here to touch on merging the patient practitioner experience into a clinical experience that meets the needs of both sides. Now, sometimes what we envision as vision care providers differs from what the patient and the kids expect in the clinic. As doctors, we want to halt or slow the progression of myopia. Parents want that, but they also expect an experience that starts from the very first time that patient or their family member calls the office, speaks to your staff members. What kind of treatment do they get? What kind of feel do they have when they walk into the clinic for the first time? How has wearing orthokeratology lenses at night changed things during the day for you?
So I play softball, and when I put them in at night, the next day I have vision till like 9 o'clock. So whenever the batter hits the ball and it comes flying in the outfield, I have my glove ready and I can see the ball instead of just being smoked in the head.
So for this little guy, one of our Myopia Academy patients, he's happy if he's not getting smoked in the head with a ball. On our side, in the back end, we're managing, all kinds of things, including optimizing health for our patient. We're wanting to slow or halt the progression of myopia while providing good quality vision along the way. So that's our medical perspective. Now, from the patient side, like I mentioned before, we're also trying to align with a business model. And so from a practice management perspective, the flow of your patient from start to finish, the advertising that you put out, what happens when the patient comes through the clinic, and what happens after you've established that they're enrolled in your myopia program. How do you follow up with them? And how do you attract new patients into the clinic? Now, currently, we've come a little bit of a ways from where we started off in the journey. Again, Dr. Kading already touched on the general sort of idea of where are we at, but I always love to kind of bring things back to home where we're at in 2019. And so today, we know in general, our primary scientific approaches in the clinic include pharmaceutical management therapies, and optical management. Now I have optical bolded because of course this webinar hosted by Euclid does have a key focus on orthokeratology, which we'll get into in greater detail, and it was one of the optical management strategies. Now, point number 2 here is where we have come as far as the efficacy measurement. How do we know that what we're doing in the clinic is actually working? You know, no longer do we just consider looking at spectacle refraction as a measure of how effective our treatment is or how much or how little we're able to slow. We also consider a cycloplegic refraction, and often the axial length measurement has become the gold standard. Now both are correct. Of course, with orthokeratology, I really like the axial length measurement because it does not require a complete washout of your patient. You know, when you're trying to figure out if there is progression, that's an important thing. And again, it's, you know, it's very easy and straightforward to measure, compare, and analyze that kind of data. Now, a general point number 3, this is kind of a hodgepodge of sort of my highlights of where we're at and things that we need to be up to date with. Today, we have gotten to a place in our clinical practice where formalized myopia clinics are kind of the new thing within regular practice. Now, myopia clinics initially started to grow within our academic settings. And so we've looked into, you know, the leaders in research and, you know, what is being done in the schools, what is being done in some of our kind of specialty services like Treehouse Eyes, for example, globally to kind of formalize these clinics. And now in 2019, we're actually seeing that these types of specialty focuses within optometry or within vision management actually do belong within your practice. So I always like to remember in my clinical practice at the very beginning is when is the best time to intervene. So from this slide on, I'm going to give a brief overview of kind of the idea of when do we intervene, what are the treatment strategies with a path, a flow path into orthokeratology. And today, the best way to actually consider intervention is as early as possible. So in general, we like to consider children under the age of 16 or adolescents under the 16, although it's not always limited to. I do have patients in my clinic that could be 15, 16, 17 years old while we educate and let them know that this type of school age progression that we target with myopia control therapies is usually kind of plateaus out after the age of 16. There are some cases where we see progression and it's absolutely not incorrect to treat beyond. But just, you know, as you're starting out and getting to, you know, understand your clinical protocols and decide what works for you, in general, any child or adolescent under the age of 16 who's outside of their emmetropic age norm should be considered a suspect for the myopia control program. If we see myopic progression of a half diopter or greater per year, or any type of myopic shift as children grow, that could be a flag that we might want to consider intervention. And parents or siblings with myopic refractive error is a huge risk factor. Now, I'll even start to plant the seed very early on. So you see the little kiddo in this photo, my niece. You know, at this age when we start to see very young children, even younger than this, who have maybe their older siblings are already myopic or parents have high refractive error, we're planting that seed by priming them to start to maybe give a brochure on what they might expect as the myopic shift happens, if that happens. The earlier the better to start giving information to these families. Now, the therapies today, as we kind of briefly already talked about, we have pharmaceutical and optical options. Within our optical general categories, we have contact lens therapy and spectacle therapy. We tend to reach today a little bit more for the pharmaceutical options or contact lens options, although the industry is doing an incredible job of working to improve the efficacy of the spectacle options to get that efficacy up to the level of pharmaceutical and contact lens therapies. Within our contact lens therapy options, orthokeratology and soft multifocals fit in. And again, you know, oftentimes we do see as we're understanding the, you know, the right dosages and what the long-term effects are on children, and, you know, creating research studies within our academic institutes to kind of, you know, continue to expand on the pharmaceutical side. Generally, quite often, what I like to do first is I'll reach for the contact lens therapies first and then add the pharmaceutical therapies as adjunct if we're not finding enough of a treatment control first through the therapies that we do have that longer safety record of. Now we do, just to be very clear, all of these therapies are correct. It's definitely better to do something than do nothing. And the message is not that, you know, I'm not trying to bias you into choosing one thing or the other. The answer is, you know, by practicing from an evidence-based approach, you'll best be able to serve your patients. And so you have to make that decision for yourself, you know, by staying current on the literature, keeping up with what is the latest and the greatest with the pharmaceutical prescribing, you know, what is happening with spectacles, what is the best in the contact lens world as far as the right lens design. It's always evolving and changing. And so the message is to stay current and to make decisions that are based on an evidence-based model that that works for you in your clinical practice. One of the things that I've picked up along the way that has been greatly successful, both in an academic environment and also in a research environment, or pardon me, in a clinical environment, is to embrace contact lenses for youth. And this has been especially apparent to me since returning from an academic kind of environment at the University of Houston or Pacific, you know, wherever you may have been at one point into clinical practice. Contact lenses for youth sometimes can be a little bit intimidating for some of us, intimidating for our staff, but in reality, kids are very, very robust, do extremely well with contact lenses. And so I would argue that some of the kind of perceptions about maybe why you may in some cases be a little bit reserved to consider contact lenses for youth and even for very young children include things like, you know, children are fearful. They don't have the attention span. These are perceptions. Maybe the application and removal is perceived as being very difficult, and you really wouldn't consider a child, you know, to be fit to be compliant with the care. Now, in reality, children are trusting. Children are very motivated. Their families are very motivated. And when there's a good team around the child in the medical team, that's coming from you, from your vision care providers, a team coming from family or siblings, children are also very coachable and in fact actually have been shown in the literature to have a lower complication rate, for example, than teens or college age kids. And probably for obvious reasons, because a lot of the time, pediatric contact lenses are controlled in the home and supervised more heavily by the parents. Now, along these lines, always reinforce compliance, because this will make or break your myopia practice if you're fitting contact lenses. You know, like any medical therapy, the devices are safe when used as directed. And for all of us to be able to continue to prescribe these types of things in a pediatric population, we are very responsible to keep that high level of compliance, the standard of care, avoid going outside of, you know, what the, you know, the literature shows to be safe, and offer the best outcome for the patients and their children. Now, in addition, we'll talk a little bit about the structure of the eye and what we look at when we're deciding what type of therapy to choose for our patients, and specifically how to fit orthokeratology. But kind of back to the basics of when we're evaluating our patients in the myopia clinic, in addition to considering the physical structure of the eye, and when we're choosing what therapy do we recommend, is it pharmaceuticals, spectacles, which contact lens therapy, we also want to consider the patient as a whole person. So looking at things like age, their attention and maturity, where are they at on that scale? What kind of lifestyle do they have, or hobbies do they have? You know, for example, do we have young children that are swimmers? Or do we have parents and siblings that wear soft lenses or glasses? These types of things are very important to consider. So paint a picture initially by, you know, interviewing your family, interviewing the child, and in addition to measuring the eye in the clinic with all of our usual kind of workup for contact lens therapy, also consider who's that person that's sitting in the chair looking at you. So in regards to orthokeratology and soft multifocals, because as I've already alluded to, this is an Ortho-K focused event. And so I'm following the tree from the options pharmaceutical, optical, we're going down the optical train. Now we've already decided, let's skip ahead because in this lecture, I don't have time to go through every step as far as the patient selection, but I'm going to stop here and help you with how do you choose a hard lens versus a soft lens, because that's kind of where we're at in this, as we move into orthokeratology. How do we select an Ortho-K patient from a soft multifocal patient for our myopia control? Now, generally, we like to consider spherical refractive error between -175-ish and -6. No cylinder over a -2 with the rule is definitely best. And we also want to generally at least pay attention to what kind of astigmatism a patient has. So if you look at this image, this would be an example of limbus to limbus astigmatism. The reason that we care, which we'll talk about in the kind of the fluid dynamics beneath an Ortho-K lens in slides to come, we want to have, you know, a surface that has a shape that is actually fittable with an Ortho-K lens. So what I'm saying is that if the surface is too asymmetrical with too much astigmatism that's stretched out the way it is in this picture, limbus to limbus, it can be more difficult to fit. And maybe in those cases, we would consider a soft multifocal to be a better option. So astigmatism greater than a -2, those refractive error powers that are outside of the, you know, -2 to -6 range. And then of course, you know, things like pupil size do impact our decisions. One thing just to note as well, in regards to myopia control or myopia management therapy with contact lens options based on the defocus theories, we do require a certain amount of peripheral plus. And again, I'm kind of assuming that based on, you know, Dr. Kading's prior webinar through Euclid and also some of your background experiences, you know, that we do know that the therapy is based on kind of a peripheral plus that we induce by using Ortho-K or soft multifocals. Now, if we don't have a high enough refractive error in our Ortho-K lenses with what is commercially available today in terms of lens design, it's very challenging to actually, you know, push that plus in the periphery. So the eye that is a -2, we would expect about a -2 peripheral plus, and that is starting to be adequate for myopia control. Under a -2 is harder to correct with Ortho-K anyways, and we usually don't get quite enough peripheral plus in that case. And so maybe those lower refractive myopes are better off in a soft lens where we can actually control the plus power in the periphery. Now, pros and cons of Ortho-K for young children. Of course, there's cons, but let's focus on the pros. And so parents have more control, which we've already talked about. There's no need to manage them during school. So I love orthokeratology, especially in a younger population, because when they're at school, you never need to worry about their teacher calling because their lens fell out or something got in their eye or they're struggling with their lenses. You know, the kids are less likely to lose lenses that they don't actually wear. So these are kind of things that we would maybe communicate to parents when we're discussing the pros and cons of all the different lens options. And then of course, in young children, myopia control or myopia management, the halting or slowing of the progression of myopia is a huge pro of this type of therapy. Now, today's orthokeratology has actually shifted a lot. And today we have very high, good quality materials that are available for and approved for overnight wear. And so again, with Ortho-K, no need for daytime correction. Wear the lenses during sleep and in the morning, take them off. It works really well for young children. And that's kind of where we're at. The materials are fantastic. Today, we have very sophisticated designs. In fact, you know, our industry globally has done an amazing job of creating these multi-curve designs based on, you know, algorithms that they have evolved through millions of prior fits. And so we really are dealing with industry that is, you know, cutting edge and offering us solutions and different designs that are suited, especially for this population in children, and also to customize as we learn more in the research, what is the best design for myopia control. The industry is right in there with us. Now, another point to make about where are we today in our orthokeratology story is that we today do definitely understand the need for topography. And so in reality, a lot of our empirical designs, you know, technically we can fit, you know, lenses based off of things standalone, like refractive error, the shape of the eye, so keratometry, those types of measurements. But today, our industry and in the clinic, we certainly understand that the need for serial corneal topography is extremely important. And, you know, for those that are just starting out with orthokeratology, I'd strongly encourage you, and almost, you know, yeah, definitely just keep it a strong suggestion to make sure that you do have a corneal topographer access to it, because really that is the best and most efficient way for documenting if the, you know, how much the lens is working and, you know, what your treatment is doing. Now, finally, of course, the last point on this bullet is that today we have a commitment. And we see this today more than ever before. As we kind of talked about a little bit earlier about compliance and the decrease of risk, you know, I like to stress this point because, you know, we can blow it for everybody if we don't follow this key value within orthokeratology practice is, you know, right off the bat in the beginning of your clinical kind of journey when you're fitting these lenses and when, you know, you have a dispense with a patient who's getting the lenses for the first time, whether you're, you know, a rookie or advanced fitter, don't get complacent with this education piece, because today's orthokeratology does require all of us to have a very high level of education that we pass on to the parents and the families to be successful. Now, the journey isn't really over. I mean, today we've come a very long way, but we're still learning all the time. So just know that as we're you know, doing incredible things with our orthokeratology designs like the Euclid Emerald and many other designs on the market today, we're still evolving it continually. And I can assure you the folks at Euclid, you know, work tirelessly to work on the latest and the greatest, including some of these kind of controversial sort of things to keep your eyes open for in the literature. You know, what is the effect of the blur from the astigmatic cornea? You know, what's happening with aberrations in our Ortho-K kids? What is the optimal corneal treatment zone size? And so these are just a few questions. Just, you know, just know that the journey is still going, and it's going to be a continually evolving device that we all, you know, will see the industry push forward as time goes on. All right, so some of those kind of key background points now, I've gotten them out of the way just in case you didn't see the first webinar, so that we kind of have the background. So we know we have treatment strategies available in 2019 that are starting to follow kind of a consolidated clinical effort to create sort of a specialty focus. We have cutting edge products that are available to us, including orthokeratology. And now, how does orthokeratology work? Now, it's based on the fluid forces beneath the lens. And so in this diagram, basically, and this helps me a lot when I consider fitting Ortho-K in any lens design, is, you know, to get the lens to be effective, one of the fitting goals is to have a uniform seal where we have this kind of touch and seal that actually extends around the landing zone of, you know, of whatever lens it is that you're using. And then the reverse curve allows for this sort of fluid, this sort of, I guess it's the peripheral plus area, but underneath the reverse geometry curve, we actually have fluid that has more space than the landing zones. Now, centrally, we don't have a lot of space. We're also not aiming to smash that cornea down. And so these lenses are customized very, very specifically to match specific base curves and spaces of each individual eye. And our goal, which helps in our fitting philosophies, is to understand that the reason that Ortho-K is successful and that it works is because it creates kind of a push and a pull force. And so where there's more fluid, we have kind of a pulling force that creates the essentially flattening in the center, or kind of the migration. We're still, you know, understanding in the research community exactly what all of the parts of the cornea are changing in Ortho-K. And then that heaping here, which is underneath the reverse curve, created by that kind of fluid force. And then again, another seal here. So you can imagine that if we don't have that uniform seal all the way 360 degrees around the lens in the landing zone, and keeping that kind of mid-peripheral space with fluid under it, we wouldn't have enough of a pull or a push-pull force to actually have the orthokeratology be effective. And that's where we get partial treatment. And you'll learn a lot more about that when you tune in for our Toric webinar, which is the next one following mine, but I will touch on a few things about it. Now, the peripheral plus heaps up here under the reverse curve in Ortho-K lenses. So it's similar to a soft lens myopia control treatment, the difference is that we're actually putting it right into the cornea instead of having the multifocal with the center distance and the peripheral plus, which, by the way, of course, those designs are still in progress too. What is the optimal, design? Who knows? Now, centrally is where we have that minus correction. And so this is why anybody can wear Ortho-K lenses for that clear central distance vision, but the sort of side effect, we'll say, in myopia control would be that peripheral plus heaping in the side. And the uniform seal is everything, and that will help you to understand how we fit these lenses. Ortho-K lenses are available for most corneal shapes. Generally, we select a spherical lens when we see apical astigmatism that looks like this, that is -2 or less, we'll say. We do like to avoid against the rule astigmatism. It's a lot harder to fit with Ortho-K in general with either the sphere or the toric landing. And when I discuss, there is, again, design advancements being made to look at the placement of toric or bitoric optics and shapes in all different parts of Ortho-K lenses. But typically what we talk about right now and what's commercially available when we're talking about these designs and the emerald design as well, is that the spherical design is symmetrical all the way around. This is why the apical astigmatism, which is tucked right inside here, is actually makes a good candidate for the spherical design, because the lens actually can land and seal all the way around. Whereas if we had the same amount of astigmatism in the limbus to limbus shape, the lens lands right here where we have the elevation differences on the cornea, and we may not get that even seal 360 degrees around, resulting in not enough fluid force from the push and pull underneath where it's nicely sealed. In these cases, we consider today a toric landing that has an asymmetrical sort of landing zone outside to accommodate the difference in elevation where the lens will sit. Now, this leads into kind of another kind of, I guess, bigger picture way of understanding, because the big picture understanding is really, for me, the only way that I can even, get a grip on what am I doing when I'm fitting. It really helps me to understand the concepts, and then we can look at specific sort of patient examples and numbers when we're modifying and designing these lenses. But in the big picture, it is very analogous to where we have gone with scleral fitting, in that every eye has its own ocular fingerprint. And so we see we saw in the previous slide, the difference in kind of we'll say the power map that corresponds with the difference in elevation on an eye that has not only a varying amount, or maybe one eye versus another has low versus high corneal astigmatism. Well, what is the shape of that astigmatism as well? And so by evaluating that physical structure initially and comprehensively, we can then make the best selection for lens design. Very, like I said, very, very similar to, where have we gone with scleral lens fitting, where, there was a time period that almost everybody was fit in a spherical back haptic. Now we've seen a shift in the toric or quadrant specific or asymmetrical back haptic is maybe the new norm. Now, today, the lens designs that we're going to focus on, of course, the emerald sphere for me, and then the toric is what we'll move into in the next webinar. But you could fit a sphere very easily on a spherical cornea, and also those that have a certain amount of corneal astigmatism as well. And so we'll continue to, give some examples of that as we go and be more specific about how to use the emerald design in your clinical practice successfully. Just remember, not all patients need toric, and it's the same as scleral lenses. So, we can't just assume that more patients than not will need a toric. We can't just assume that more than not will need a spherical. We can kind of, I guess, pay attention and just know that they're all different. And so evaluating properly and fully is the first place to start. It's very, very important. So how do you choose your lens design in general? Now, this is not product specific. This is if you're out there trying to figure out how the heck do I get going with orthokeratology in my practice? I want to do more with myopia management. How do you even begin to choose your lens design? And that can be a little bit overwhelming. Now, I always advise, and what's worked for me and what I do tell students and other doctors that are, kind enough to ask me for, conversations about this topic and maybe offer ideas, is that the best way is to, in clinical practice, which definitely differs from an academic setting, where we do have access to every option at our fingertips and have a lot more freedom to, explore multiple designs. In clinical practice, the thing that actually works the best in general is to find a system or maybe two systems that really fit perfectly within your practice. Consider, the geography. Where are you located? What is the shipping cost? How are your consultants? What are the products like? And choose the design or the one or two designs that work best for you and become an expert in that design. Ideally, it's great to know everything about everything, but it's not always possible. And so when it comes to orthokeratology design, certainly select one or two designs, and especially with a focus on which one works the best in your practice, and roll with it. Become an expert in that, and that will be the most effective and efficient way to have great outcomes with your patient, but also follow your business model where you're actually profiting. Now, when we look at this physical structure in the sphere versus toric, we've talked about that a fair bit already, but we also want to consider ocular anatomy and refractive error, of course. And so to fully evaluate our patients is really important to not only identify what are they a candidate for based on some of the criteria that we talked about, but just also to have very high quality, good baseline data, including your refractive error. In fact, in most cases, and what I do, or what we're moving toward in clinical practice, as much of a pain that it is, that first baseline fit, whether you're considering, your myopia control kiddo for one therapy or another, getting a really good solid cycloplegic refraction. And again, this can be done with, if you look at the literature with, tropicamide, a couple drops per eye over 5 minutes, or actually using cyclopenolate or other cycloplegic drops. It's really good to at least do that once. And then moving forward, as you develop your clinical protocol for what makes the most sense for you, while following what are research and kind of the standard of care that's emerging presents to us, you can develop your protocols that way. But I do recommend having that solid, great understanding right off the bat, so that you can have quality data to work from, to build lenses from, and also to go back and compare when you're looking to see how effective your therapy actually has been. Now, getting more specific at when we are keying into orthokeratology. So now we've made the decision for sure, okay, we have our kiddo who's a swimmer, younger maybe, and we have looked at their refractive error. It would appear that they could be a candidate for orthokeratology. Let's look a little bit more closely. This is an example, and I had the same map in our apical astigmatism slide, just showing a little bit closer at some of the things that we do look at when we consider whether or not a patient is a good candidate for Ortho-K and what type of orthokeratology. So we look at that astigmatism shape. Is there astigmatism? Is it corneal astigmatism versus refractive? We know that if we see a higher amount of corneal astigmatism compared to a patient's refractive error, sometimes it can be a little bit harder to be successful with your orthokeratology if that's coming from lenticular astigmatism. The only way to really know is to try it in a lot of those cases, unless you see a huge amount. I have been very successful correcting an eye that has more corneal cyl than refractive cyl with Ortho-K, and some others that maybe have not been so successful. So it really just depends. Now, eccentricity values are highlighted as well. And so we can get these values, it's small here, but I will have some examples of maps where it's blown up a little bit bigger. But eccentricity is a consideration, and I'll show you the criteria for what is acceptable and what is not in the next slide. We look at pupil size, and then also just the corneal size in general, or the HVID as well. Now, topography is really great. Getting that baseline is so important, just as important as that great cycloplegic refraction initially, all of your baseline data. Everything that we do in orthokeratology is based on our baseline map. So if you have garbage as your baseline, you're going to end up with struggles as you try to modify a lens or figure out what the heck is going on. Often, if we can put in the extra time with, either you do it directly yourself or you spend the extra time with your technicians to learn how to take that great quality baseline data, that will actually save you tenfold the time in the future. And so we want to have a nice full map without the lids in the way. If you have the option of a composite map in this particular topography, go ahead and try to do that. And that's going to save you a lot of time and, essentially speed up the process for you ultimately by putting in that work initially. Specifically for the Euclid Emerald, the FDA has cleared for children and adults for daytime myopic reduction with this lens. And we are approved for our low to moderate myopes up to about a -5. You know, we want to keep our astigmatism as kind of what we're approved for would be, again, close to the -2 range. But what we say is about a -150 to be the most successful. Now, those eccentricity values that I talked about a little bit, you do want to screen your patient to make sure that we fall within that range of about a 0.3 to a 0.7. And to be honest, sometimes I will fit outside of that. You know, we renegade things a little bit outside of these norms, or we'll push it a little bit. And again, you know, the company definitely has reasons for having criteria for your patient selection, but in reality, in clinical practice, I'll be honest, sometimes I do push it just a little bit, and the Euclid Emerald has done very well for me, and I'll give you an example of that at the very end with a case report. Now, the keratometry that we look at, you know, usually about 40 to 46 diopters, and then we definitely want to have a large enough corneal diameter, greater than 11. And at this point, if you kind of meet this criteria, or generally you would be a great candidate for the Euclid Emerald sphere. Now, I included, don't forget about dry eye, because I know this is a myopia talk, or we're keying in this presentation to talk about pediatrics and myopia management, but we don't want to forget about our dry eye patients either. And this is a plug because I like to get creative with the use of orthokeratology in clinical practice. There are a lot of applications for it outside of kids and myopia. You know, all kinds of things such as, you know, prepping a patient to test out whether they actually want to have refractive surgery or not. Dry eye patients who fail out of their soft lenses and can't wear contact lenses during the day. These are just some examples where having the tool of orthokeratology in your practice can be a major asset and a major practice builder. Our avoid patients, you know, again, that against the rule of astigmatism, these are sort of the flags to kind of avoid. Sometimes I still fit them, but these would be things that you're kind of keying in for when you're evaluating and maybe considering equally effective treatment options. You know, the lenticular astigmatism, we talked about that already. Also, don't forget to screen for ocular conditions that would contraindicate orthokeratology or contact lenses in general. You know, we are using medical devices, and with that comes the responsibility of our due diligence. And so, you know, in regards, I actually have had a pediatric patient who family history of keratoconus, you know, showed up with some warning signs or some flags at a very young age on their pentacam, where you can actually scan the posterior cornea. And so in that case, I wouldn't fit them. So always, you know, I would probably in my practice, you know, what I like to do is definitely screen for these things. The choice is up to you. But I think that these would be, especially for keratoconus and any kind of corneal condition that we could cause harm if we're not diligent, really important for you to stay tuned in and just be suspicious, be a detective, and try to look for the things. If you're not looking, you won't find them. Now, getting deeper into our corneal topography, how do we then choose? We've already kind of talked about that this webinar is about the emerald sphere. And so that would be the orthokeratology design that lands equally in a spherical kind of shape on the cornea, on the peripheral lens, on the landing zone. Now, how would we know if we need to fit the toric landing or the asymmetrical landing? Now, what we like to do is take a look. There's many ideas, and there are other ways that this can be done based on, you know, population norms and refractive error and all kinds of new ways of fitting Ortho-K for myopia. But one of the sort of older and kind of consistently effective ways is to look at the ocular shape. And what I mean by that is look at the elevation height, because what we're considering is a lens on another physical structure. And so we need to make sure that the choice that we make in terms of the lens design is a match for that physical structure, so we get that even seal all the way around. Now, if we end up with an elevation difference on the cornea that's greater than, we'll say, about 30 microns or more between, let's just say, two primary meridians, meaning that we have asymmetry and height differences across the cornea, then we may want to consider the toric. And this is just a short guide to give you a little bit of a sort of outline for how to kind of make that decision, especially when you're first starting out. Now, to look at elevation, what we often will do is use corneal topography and calculate the differences in height between principal meridians. And so you could look at the total sagittal height between principal meridians and find the difference there. Or you can also look at the average versus horizontal chord difference in regards to the elevation difference from the best fit sphere in this topographer. And I do have an example that I'll show you toward the end of this presentation. But just to kind of give you the heads up on exactly how we do that. Now, the topography software also has now evolved and has excellent tools available within it that can calculate this automatically in a lot of cases, just depending on what system that you would be using in your practice. Here's the design of the emerald. So as you can see, you know, there's a peripheral curve, their alignment curve is shown inside, the reverse curve here, and then that back optic zone. The standard optic zone radius is 6.2 millimeters. Parameters are all modifiable. And here's the lens on the eye. Now I do want to point out that usually what I see, this is a beautiful picture of what we would see in a textbook, the perfect fit. You know, look at that lovely edge lift, a nice reverse curve zone, everything looks great. You know, I do have to point out to this group, especially if you're new to fitting the emerald, on dispense, the lens probably won't look like this. You know, it's on dispense, it's going to look like there's more pooling centrally, and that can be a little bit misleading if you're hunting to see that the lens looks exactly like this fit on the first visit, just because the lens will look different on day one than it does on your dispense. And so usually what we do is if it looks adequate, you know, with a decent reverse curve zone, it's aligned, it's centered, we'll dispense it, and then see them back for the one-day follow-up, which we'll go through in the coming slides here. Euclid Emerald is really easy to fit. If you're unsure of where to start, it's always best to follow the fitting guide. We see this in all lens designs, you know, soft multifocals, all the different designs that our industry has put lots of resources into to make sure that there are fitting guides that are, you know, effective, and they do work. And so the Euclid Emerald is really simple. Get a good refraction, get your K readings, and measure the HVID. Now, all of our initial lenses with the Emerald design are based on the typical eccentricity, but this can be modified. And so again, if you do have patients that do fall outside of our standard fitting criteria for this lens design, just make sure to always work with your consultants, and they can help you to kind of decide if, is this candidate going to be, is it possible to do Ortho-K? Are we going to likely to get a good effective treatment? Now, empirical design in pediatric practice is awesome. Now we do have, you know, there's two ways to fit contact lenses, specialty lenses. We fit them empirically. We fit them based on fitting guides or based on diagnostic lenses. Both are correct. One thing that I found with our empirical designed lenses, which all lenses can be designed empirically, in the flow of a myopia management practice, kids are often always having extra testing as it is, whether that's their health exam, myopia consults, contact lens fits. Kids get tired. And so when you're fitting them for the first time, sometimes it's actually a nice gap or a break for them where you can start to prime them at that first visit, take the measurements that they need, make sure that you have all of the baseline information down, and then you send them away with kind of some positive, you know, information where they can think about it and then come back fresh and ready for their dispense appointment. It saves time. And so I find that the empirical design works just great in pediatric practice, and especially in our myopia practices. And as your myopia clinic gets busier and busier, you'll probably find the same thing. Now, once we have that RX, Ks, and HVID, it's just as simple as ordering the lenses. So we can order through a telephone call, or we can order online, and both are available. Now, also, just remember, we still recommend the serial topography. And so while we can order just based off of this information, usually the best and quickest way to get the information is to actually, you know, get it off of the topographer. Now, lens evaluation in effective Ortho-K is based on centration of the lens when the patient sleeps. We definitely want to have an adequate size treatment zone or treatment zone on the cornea that is not too big and not too small. And so in general, we'd recommend a treatment zone around, you know, 3 to 4 millimeters on the base curve of the lens. Now this can vary on the actual treatment on the cornea, and you can use corneal topography to measure this. Now we want good peripheral alignment. an appropriate edge lift, just like we would fit a corneal GP lens that's not necessarily an orthokeratology lens. So if you look at any of the fitting criteria for corneal GP lenses in general, a lot of those philosophies hold true with orthokeratology. The schedule that's recommended, we dispense a lens the next day. On our day 1 is usually 1-day follow-up as early as possible. Now, oftentimes I'll get asked, okay, do you have your kid wear the lens to the appointment or not? Now that is up for debate, I would say. There's a couple of, there's pros and cons both ways. On one hand, in theory, we should be able to see everything about what that lens did overnight by looking at the pattern on the corneal topography the next day and by staining the cornea to see if there are any cells removed from lens adherence. Then we'd be able to see. Now, I'll just go back again just to show you, exactly what's happening in this video. This is what it looks like when a lens is adhered. You can see with the blink, the lens is not moving. And this is common in Ortho-K lenses if we have, the edge fit that's a little too tight, or we're using solution that's making the lens gum up a little bit when they sleep. And so what we would see on the cornea would be an adherence ring. And so if the patient arrives to your clinic without the lens on, you see kind of a ring of adherence, then you know that the lens was sticking, you need to make a change to the landing. Then maybe we would have them put the lens back on. Now, if everything's good and they come in with no lens, then that saves us the trouble of actually having to reevaluate the lens the next day. Again, as devil's advocate again, there are also schools of thought, after we move past the 1 day, is there ever any other opportunity for us to look at this lens? I mentioned that it might look a little different on the dispense visit. And so it's your chance to see the lens one more time, because we don't typically have the lenses on for every Ortho-K follow-up subsequently to this. We would apply the lens if we're having struggles or want to make a change to the lens. And so you'll have to make that decision for yourself. I often will have kids wear the lenses if they're coming in very, very early in the morning, within an hour or so of when they wake up. If that doesn't work, then maybe I'll allow them to take them off. Just really depends. Patients are all different. Then typically the flow is next day, 1 week, 1 month, 3 months, and then 6 months for your follow-ups. At our follow-ups on day 1, and the visits after this are about the same usually. You always want to check vision. You want to do a careful slit lamp exam with staining and look at corneal health. Corneal topography, where we look at axial maps, tangential maps, and difference maps. And we'll explain that in just a second here. Always record the time of your visit. When did they put the lenses on? How many hours did they wear them at night? And when did they take them off? Inspect your lenses, because sometimes they will get mixed up. Make sure that they're putting the correct lens in the correct eye. Every visit, consider what solutions are you using and how are you using them, even for veteran Ortho-K patients. You always, always, always want to do that. Finally, don't make lens changes too quickly, because oftentimes, especially if you're new to Ortho-K, you might, and I was very guilty of this originally too, you jump up and down on day 1 or on the 1 week and don't give the lens proper or adequate time to fully do its job, and then we're kind of jumping the gun to make changes a little bit too early. Training your staff is extremely important in a successful Ortho-K and myopia clinic, because the quality of that care does rely on that full experience. And honestly, the majority of the time outside of that consultation and education that you provide one-on-one is actually with your staff. So train them on the phone triage, your consultation appointments. Do you have separate visits just with your technicians? I would consider, which we have, is technicians that are custom, or I guess that are specifically trained for orthokeratology or for specialty contact lenses. It's a huge asset to your practice if you're planning to do this more. They can become the application removal training pros, because it really is not a great use of chair time for you to be doing this all yourself. I also personally often don't have the time, and I'm definitely not as good at social media compared to some of my technicians, and they do a great job. And so you can get assistance from your staff by designating them or hiring somebody to do marketing and social media for this type of practice. Now, our difference display maps. So kind of when we consider corneal topography, so we want to figure out what is the treatment that's happening on the eye as after we wear the lens overnight. And so what we do is we take our excellent baseline topography and then we compare it to our next day visit, or our 1 week, or our 1 month, and look at the difference display between baseline and post-treatment. Now, when it comes to the topography, probably the most valuable thing that we get from that topography is centration. We want to look at where does the lens position during sleep. And the best map to use to look at this is the tangential map. Now we still use the power map to look at refractive change. And here's an example of that. So we can see here a baseline example, post-treatment, and we can see here our treatment difference is about a change of about 4.5 diopters. Now the same patient, here is their tangential scan. And this gives us a much more instantaneous view that's not normalized toward the periphery, that will give us better data about the position of that lens. Now you can also look here on this bottom scale, if you can see me kind of moving the mouse, the width of the treatment zone on the cornea. And that can be very important because as we learn about modern myopia management with orthokeratology or the soft lens optics, we really do want to aim all of the optic that we intend for a myopia control within the pupil. And so we look at pupil size and treatment size and see, hey, are we actually getting a treatment that's actually within this patient's pupil and expect it to be successful. One thing to point out in these maps is often if we are using this system, for example, which is very, very commonly used for Ortho-K design, there is a kind of a standard or universal curve difference. So how do you get your map to look like the textbook one? Kind of the rule of thumb is we want to adjust our scale on the side. You can see that this goes from 4 to -4 diopters. And in general, if I was to be wanting to correct a total of 4 diopters, it's always kind of the nicest to use the scale on the side that matches that. So 2 and 2, so kind of the total of what you're trying to correct, just so that you can see that change a little more easily. Here's the same map with a different curve. So you can see now that I've made this map stretch out a little bit so we're not wasting the data on the ends, and it becomes a much more clear piece for education for your patient and for you to really clearly see what's happening. And this looks a lot more like those beautiful textbook, well-centered curvature maps that we see in our, our CE and our training videos. And the only difference is the scale, basically. So just pay attention to that as you're evaluating. As long as you can evaluate apples to apples and kind of understand what you're doing with your own maps, you're set. Now I do have this clinical adjustment guide is available to you by Euclid. And it's a fantastic guide that gives you information about what to do when something goes wrong. And so on the top is that kind of typical, beautiful, no problem treatment zone. But what do you do with the central island or inferior decentration? This is where we see the treatment zone inferior on the map. And we know that's where the lens is positioning down when we sleep. What does it mean when it's high? I always have taught students, and consider it in my own logic, the lens will behave similar to a regular corneal GP. So for example, the big belly hangs low in our inferior. So this would be an example of where maybe the height of the lens is just too big or the lens is too steep. So to correct this, maybe we would flatten or change the curves to provide a little bit better centration. What about the superior, the lens riding high or sliding all over the place? Well, similar to a corneal GP, that could be a flat lens, and etc. So this is a great guide, and this is just the tip of the iceberg, but it works really well to refer to in your clinic. Now, a couple last points before a brief case report, and then we'll open up to questions. Just to bring some clarity to the fitting process. Now, when it comes to empirical lens design, it can be just a little bit intimidating if you don't feel that you understand all the curves available for modifications. And I know in some of the, marketing of the Euclid Emerald, we talk about the lens having proprietary curves. Basically, I've learned by working with this lens is that we can change parameters essentially as much or as little as you want to. And as you understand the process, you can start customizing. And so it's not a blind change. You can send in topography, for example, and results and have consultation look at it. Or you can actually learn more about the lens curves, which there are resources out there to help you do that, and customize lenses based off of changing specific parameters that you actually want to. And again, if you're unsure where to start, just remember those steps 1, 2, 3. You can always go back to the basics. Another kind of piece that's, a point of contention in the circuits is, optic zone, does it equal treatment zone or whatever? Just know, this is just kind of an aside as well, up on a soapbox, but the optic zone of the lens does not necessarily equal the treatment size. And so you do need to measure this. You can look at it on the the topography with the change map and kind of figure out, we definitely can adjust the reverse curve and sagittal height of the lens to achieve larger or smaller treatment zones when indicated. And these lenses are fully customizable. So just know that when we're working with this lens design and others. Now here's a brief case, and then we'll move into our question period. So here's a 6-year-old male back in 2016. And so this is a patient in my current clinic that I've inherited. And so there's a history of the path that this patient has taken, and it's very, very common. So we have a 6-year-old male, family history is positive, parents with high myopic refractive error. January 2016, -150, glasses. October 2017, pretty big increase up to -275, -250. So at this point, we at our office recommended myopia control strategy, gave education. This will happen to you too. Patients will get all the information. They may not choose to proceed yet. It could be the very first time that they've heard this information, which is why it's even more important to prime early and plant the seed early on. So as soon as you see a young child, don't wait until they're -3 or -4. If you see parents with high refractive error, the first time you screen their baby, you may want to, in a non-ominous way, you don't want to scare them, but start to just mention what the risk factors are for increasing myopia, just so that when the time comes, they're ready for it and they're ready to proceed before things get higher without treatment. Now, April 2018, -4, -375, so started atropine drops. April 2019, now just kind of another piece of information in between. 6 months after starting atropine, refraction was stable. And then another 6 months after that, that's when we saw the increase here. And so at this point, perfectly appropriate to consider adjunct therapy. Initially, parents were not really comfortable with contact lens therapy. So at this point, we moved into the conversation about soft versus hard. It's perfectly appropriate to use an adjunct. Now, looking at this patient as a whole, competitive BMX biker, no older siblings had contact lenses. Parents just wore glasses. Mom definitely liked the idea of no glasses or contacts during the day. So at this point, I basically, based on refractive error in my mind and based on the history, decided on Ortho-K, and parents were on board. Now, evaluating the physical structure, very important. So as we continue on, we are strongly considering Ortho-K. We also need to look at our criteria here, make sure that we meet what our criteria says is most likely to be successful. So our -4 kiddo certainly falls into this category, fairly young. And then of course the hobby of the BMX biking, of course, it's going to be a great option for no glasses or contacts during the day. Now looking at the corneal topography, here's the baseline, and you can see flat and steep Ks fall into our fitting criteria for the Euclid Emerald lens. Now our eccentricity values were a little bit interesting, just slightly outside of the norm, and this would be an example of a patient that I did decide to proceed with. And so, you could talk to consultation. I just went forward with it, and because we don't really know, the consultation team also does take into consideration these e-values and can redesign parts of the lens to better accommodate this, and that's what we did. Now the refractive error, so we know refraction is a -450, and this is just the right eye, just to give an example, but of course we did do both eyes. Here's where we get the Ks from, and then the HVID in this particular topography system is measured here, and so we're above the 11 millimeters. We should be good to go. Now the HVID is also helpful to be able to design your lens diameter too. Sometimes larger HVID, patients with a larger HVID they will do better with a larger lens. And so just keeping all of that into consideration as you're considering your design, and custom modifications to your design can be a lot of fun. Here's how we use the elevation difference. And so in this particular map, same map, all 3 maps are the same, just different views. This is generally about, if I was to move my cursor in an elevation map to about the diameter of where the lens would land, we're looking at about this space here, we can collect an elevation height of about a plus or a minus 20 on either side in the horizontal, and a -50 in the vertical. Now on average, that gives us about a 40 micron height differential between those elevated points. And so this patient actually did technically fall into the category that we would potentially consider to use the Emerald Toric. And actually here, I think I might even have a typo. So the difference here, just to be clear, on average, 50 microns, 50 plus 50 divided by 2. Oftentimes the values will be different. I've rounded this just for simplicity in this presentation to give you an idea, just in case this is your first time looking at this. But the average in this meridian that differs from the best fit sphere would be a minus 50. And then on this meridian, we're looking at a minus 2 or minus 20. The differential is actually a minus 30. That's a typo here. And so this patient had fallen generally right on the border of when would we consider a toric landing lens or a spherical. We went with the sphere just to keep it simple and see what the lens looked like on the eye. And that's perfectly acceptable to do. It would have also been correct to try a toric lens with that low amount of toricity, and we will get into that in more detail in the next webinar, so we certainly hope you tune in for that. Here is the one-day map, and we got about 50% reduction of this patient's refractive error, so great start. Again, just because of the time, we don't have time to go through every map and every follow-up, but in general, very successful outcome based on the 1, 2, 3 fitting method. Pretty straightforward, but very valuable case that highlights kind of some of the basics of a patient who's a great candidate for this type of lens and who actually ended up with a fantastic outcome. Now, in conclusion, just remember that doing something is certainly better than doing nothing. And I always say this, I always love to end presentations with, just encouraging those of you that are out there learning about this for the first time. Anybody that has experience started out with no experience or little experience. And so, staying connected in our fantastic industry to build and differentiate your practice today with proactive myopia management is the ending message. So I'll just pass this back over to Jane so that we could move forward with any questions that may have been submitted.
Wonderful seminar, Dr. Morrison. So many interesting observations and certainly tips I can take back to the clinic tomorrow. So that's just what we want. So let's see if you've, I see we do already have a few questions posted. And if you're out there and you have questions either for me or for Dr. Morrison, please go ahead and type them in and we'll see what we can get. So question number 1, Dr. Morrison, do you recommend any specific topographer, or what should we be looking for, I guess?
Yeah, I do get asked that quite a bit. It's interesting. I actually had a inquiry about that this week actually. And generally, I would say that what you want to do, whatever system you choose, check in with your lab and make sure that they're comfortable with that software for that unit. I would say probably a Pentacam and Medmont are the most commonly used. There are other topographers out there. Some of them are older that work equally well. But the catch is today is finding the software that will actually work with our current designs and specifically what designs that you might want to work with. Personally, I like using Medmont for lens design purposes. There's just more options in the software. Just using those 2 kind of common ones to give you a few pieces of feedback. I also love using Pentacam, especially for pre-screening for keratoconus or prior to, I guess, initiating Ortho-K fits. So I think that they both have their place, and I would definitely consider who your lab is, talk to them about it, what software are they comfortable using, and just make sure that you can easily be sharing data between you and your consultants.
Yeah, I think this is an area where the industry is really playing catch up. I know here at Euclid, we often get requests about working with different systems and trying to get accuracy built into them. So I think price points are going down and information gathering skill is going up with any of the systems. Absolutely. Okay, let's see. I'm going to jump down to at what point, Dr. Morrison, or at what age do you stop Ortho-K? What's your correction or your thinking?
I actually, lots of our patients will stay in Ortho-K indefinitely into adulthood, but not for myopia anymore. Ideally, we see today in general that type of school age myopia that we tend to talk about in our lectures and what we've learned about as far as what we're actually targeting. We do expect it to kind of level out after the age of 16 or 17. However, what we're learning today about myopia in general is that, things that we thought we knew, we're finding out that there's a lot we don't know. And we suspect that there are likely multiple types of myopia within each category with a very multifactorial etiology. And so I would say that it's based more on I don't have a hard age for when you would stop. I would say we stop if we see the progression stopping. And once we're past that age, if I had to pull a number, just to say, I would say probably 16 or 17, maybe 18 would be when we would expect on average and what we do see clinically where the myopia, generally that type of school age myopia will slow. But I do have patients that are older than that that still are progressing. And in those cases, sometimes we suspect that there's a component of maybe more pathological or other factors as well. I think that it's not incorrect to keep them in Ortho-K. And like I said, in reality, what actually happens in a practical way is that patients that are used to Ortho-K often will keep going with it or seek out refractive surgery when they're done the therapy. And so at that age, we're looking at stability of prescription for into their kind of, early to mid, maybe late 20s to consider the surgery. And a lot of those patients are aiming toward that. Slow it, keep it as low as it can be to keep them a candidate for refractive surgery in the future so that they do have that option and don't climb so high that they couldn't consider be a candidate for every therapy.
Yeah, now I've got a question here from Beth. What do you recommend regarding pupil size with standard spherical lenses? What size drives you off one way or the other?
I would say, I think that today you can modify the zones. I usually would probably reach for a soft lens option with, and this is not based on evidence that we have. We still are working on, peer review sources to really give us the gold standard for that. I just myself, if the pupils, in normal illumination or in kind of mid illumination are smaller than like a 6, I'll definitely reach for a soft lens. But I don't really think that that's something that I am aware of that's, hard in stone. In general, larger pupils do better with Ortho-K for myopia control. And the smaller pupil size, we would maybe reach for the soft multifocal just as long as that optic is making it in. And to be honest, I don't know that in either design that we're really 100% sure of what is happening within the pupil 100% of the time. In an academic setting, we can measure that. And, our academic partners and, researchers at the schools certainly are doing that right now and looking at that. And so, again, that's a topic that in the clinics, we, stay tuned for more of a standard of care to come down from those higher kind of bodies that are doing the research.
How about this one? Is there any risk of central scarring or haze in the cornea?
Yeah, so there's always risk with any kind of hard lens if you're inducing touch and epithelial staining or defects. I think that in general, the literature does show a very low risk of that type of complication in well-fitted Ortho-K lenses.
Do you offer glasses or soft contacts of some kind with a small amount of residual correction for end-of-day blur if they need it? And how do you present that issue to parents?
Mm-hmm. So I think what I've done in the past is, in general, the population that seems to appreciate that as an option would be older. It's very rare that I have had my patients that are younger, so under me, I don't know, depending on what their activities are, maybe between 6 to 10, it's not likely that they're going to be able to really even communicate or have the tasks that really demand to correct that end of day blur, depending on how great it is. And in most cases, it's not huge. I do have patients though that are older, that are more of driving age, maybe a handful or less, not even a handful actually, because in most cases, once they've been on the therapy, I do find that end of day blur is quite small. But driving glasses or distant viewing glasses, just with that extra little bit of correction, is definitely something that I do if they have complaints. Another application for, glasses or contact lenses, just because I thought of it when this question came up now, is the possibility of the in-between stage. So what do you do for these patients that when they're in the first month of treatment where the end of day blur is greater, maybe even the first week they can't see anything halfway through the day, or they're back to 3/4 of their full correction. And what I'll do then is dispense a kind of several different powers of daily soft lenses if they can wear them, just to tide them over until the treatment is good enough. And I certainly don't change old glasses. So say you have your myopia kiddo who has seen a progression. Now maybe their diopter higher, their glasses are now outdated, I certainly do not advise that family to change those glasses if we're considering Ortho-K, especially not right away. In a perfect world, you do need to have optical correction in glasses for every contact lens patient 100% of the time, because they could get an infection, or there could be times where they're not able to wear lenses for one reason or another, or they lose them. So they need to be able to quickly go back to something that does give them adequate vision. But those in-between glasses, where it's maybe older glasses, and a lot of kids will have these kicking around, can be great for those in-between times as well. So I wouldn't throw them away. I wouldn't change out all those old lenses. I'd let it all kind of settle and see if they can be useful at some point.
Well, we have a question here about what is your warranty policy, and I'd like Dr. Morrison, if you'd answer that from your office.
Sure.
I've also got online David Bland, who is our Euclid VP of sales, and David can tell you a little bit about our Euclid warranties.
Yeah, that sounds perfect. You know, I have actually a spreadsheet in my office that has warranties, and I believe I want to say it's 90. I'll probably refer this over to David. But all I know is that when we use this lens, the warranty is competitive with all the other ones and has adequate time. So I think it's a 90-day. You can make exchanges as needed. And I think probably at this point, I just know that it's competitive and actually a little better than some of the competitors. So what I'll do is maybe have, David, are you okay to take this one now?
Sure. Can everyone hear me?
Sure, David.
Yeah, the warranty is, you're right, Sheila, it's 90 days, 2 exchanges at no charge, and we don't require the lenses to be returned unless you're canceling the order, and there is a 30-day cancellation option as well. So the warranty is really designed to give a lot of security once you're getting started. And if you've got any questions, I would also highly recommend working closely with the consultants. We have 7 full-time consultants on the phones.
Okay, we've got a follow-up question. So Dr. Morrison, how many days can your average patient go without wearing their lens and still restart with full power? Now that's kind of a catch, full power. What do you think?
So are you asking me, Jane, how many days could they not wear lenses and still have full correction? Or is it how many days do they need before they're back to their full correction without wearing the lenses and needing that glasses or daytime contacts?
My interpretation, well, Bobak said both. He'd like an answer to both of those questions, please.
Yeah. You want me to just answer both?
Just hit them both real quickly.
Yeah, real quick. So typically it varies. So as far as the ability for the eye to retain the treatment, there is no answer. It really depends. But in general, the longer they've been in Ortho-K, the longer that they will hold without. So I do have colleagues or kids that will occasionally go a night without wearing the treatment and they're perfectly fine, or maybe even 2 nights after they've been in them for a very long time. I have adult patients who maybe only wear the lenses, you know, maybe 5 out of 7 days a week or less. Now, usually though, kids, especially in this type of context, they're especially when they're new in the first year, they will start to go back within a day or 2. I just had a patient, an adult, who lost her lenses got stolen this week. She's from the UK, and she was in a panic trying to figure out if she could just get back into lenses, but she actually washed out faster than we could even get new lenses. So we're just refitting. So everybody's different. The answer is it varies, and the longer you've been in the treatment, the longer you're likely to hold the treatment. And typically the washout period to go back from, on average, from full correction to no correction, meaning that you're back to your full strength glasses, would be typically anywhere from 1 to 3 weeks. And the way to monitor that is, number one, looking at refractive error, but looking at the topography, because if they still have partial treatment, there will be kind of a flattening sort of appearance in the center of their refractive power on the topography. And if they're back to normal, then you'll see that kind of regular full, even on almost a spherical eye, you can see in topography that it almost has, nobody is a perfect sphere. There's always a small amount of astigmatism, even if it's considered a sphere.
Okay, I got one final question because it's getting late. So
Sure.
Dr. Morrison, you've recently moved and gotten back into private practice. Have you been able to say it's Ortho-K has helped you grow your practice?
Oh my goodness, I couldn't stress that more. Ortho-K has been incredible. The office, my practice with the amazing colleagues here have already laid the groundwork, and I've been very fortunate to walk into a very busy specialty kind of environment as it is, and where they were already doing some amount of Ortho-K, but since I've arrived, it certainly has been an amazing practice builder for the office and also for myself, of course. As you know, it's an interest of mine in research and in, just in practice in general. And some of the really cool things that happen, it's more than just the dollars. It is very financially profitable, honestly, if you can get your Ortho-K practice running smoothly with efficient staff and smooth protocols, and working with labs that honor you and work with you and provide incentives for business and things like that. The whole other piece of any specialty within your office, and especially Ortho-K for myopia, is the referrals. Kids that go to school wearing glasses and come back without glasses, and every kid wants to talk about it, and then they go home and tell their parents, and then their parents talk to each other. For every one Ortho-K patient that I do a great job with, it's just a tree of new referrals, whether they're for Ortho-K or for their families to come. And so Orthokeratology being it's definitely not novel. It's been around for a very long time, but it is a subspecialty interest within our specialty lens focus in vision care. And, not just optometry, but our whole community, including all of our vision care providers, our labs, all of us, right? It's definitely something that sets you apart. And I would wholeheartedly answer that with a solid yes.
Wonderful. Well, I want to remind each of you, Dr. Morrison has mentioned it a couple of times today or this evening. This is a series we've been doing, and be looking forward to upcoming announcements about our next Euclid webinar, and it will be on understanding and fitting the asymmetric toric designs that she spoke of several times for Ortho-K. I want to thank you all again. On behalf of all of us here at Euclid, please don't hesitate. We have a slide up there with David's contact information. He can help you if you need to open an account, or if you've got questions about warranties, or if you need fitting guides and materials. Thank you all, and have a very good evening.